Good evening, everyone. The meeting is live. Good evening, our president, and I welcome our president, Dr. Naveen Malhotra, sir. Sir, with your due permission, with your kind permission, should we begin the meeting?
Please start.
Dr. Nishant, over to you, please. Dr. Nishant.
Maybe begin, Dr. Vishal? Naveen,
Please,
sir?
sir. Please, sir. Please begin, sir.
You make him host also. Over to you, Nishant. Unmute yourself.
Sorry, maybe begin, sir?
Please start.
Yes, sir. Yes,
Nishant.
please.
Right. Okay, sorry. So a very warm welcome and a very warm welcome to the first webinar of the RSA webinar series, and a very happy new year to everyone present here. I can see a lot of seniors and dignitaries present tonight. And today is a special day because this is the first webinar of the RSA webinar series. And also, this is the day where we will be releasing the first newsletter of the RSA, the Research Society of Anesthesiology. And today is this webinar is being conducted by the RSA branch of Bihar and Jharkhand. And to begin the session, may we kindly request our president, RSA, Professor Naveen Malhotra, sir, to introduce the session and welcome the dignitaries.
Wish you all a very happy new year. May you and your family be blessed with good health and happiness. May all your cherished dreams come true. Keep on doing good work. Feel proud of yourself and make us feel proud. I, Dr. Naveen Malhotra, President, Research Society of Anesthesiology, cordially welcome you to the first academic webinar for the year 2026. I am joined by Professor Tej K. Kaul, our patron, Honorary Secretary Dr. Vishal Singla, Honorary Treasurer Dr. Sunil Sethi, and I'm very happy. Not only today we are going to release the inaugural issue of the Research Society of Anesthesiology newsletter, but this is the first webinar by the Bihar and Jharkhand state branch also, and we shall be discussing about the intraoperative emergencies, and we have got luminaries amongst us, including Dr. Dev Sanjay Nag, Dr. Ashok Jadon, Dr. Pradhan, who will be throwing lights on the different emergencies which occur intraoperatively. It's an honor to release the inaugural issue of the Research Society of Anesthesiology newsletter named as the RSA Times. May we have the video, please, Dr. Nishant? Thank you, Nishant. Now it's an honor to release the inaugural issue. Please project the inaugural issue, Dr. Nishant. And if you can just scroll it down. So it has got messages from the patrons, the president, the honorary secretary, joint secretary, all the academic activities and membership wellness programs done under RSA, the way forward leading to Golden Jubilee, women in anesthesia, anesthesiologist in leadership roles by Vice President, and this is the Chak review, MS with pregnancy with severe MS by Dr. Nani Hemant Kumar, past President, and the debate about the segmental spinal by Dr. Savarna K. and Dr. Iren Shah, and then about the career advice in cardiac anesthesia by Dr. Munir Ahmed Khan, and about the scanning of the GOCP by Dr. Nishkash Gupta, and Dr. Nishan talking about the stats, about the forthcoming conference, the Crossworld by the Dr. Parul Jindal, and Dr. Kriplani talking about history of anesthesia in India. And about some art and literary by the Dr. Tapas Kumar Burman. And finally, I pay my thanks to my editors who are working since many weeks to bring it forward, Dr. Nishant Sai and Dr. Mayank Masand. A bigger round of applause for Dr. Nishant Sai and Dr. Mayank Masand. Dr. Nishant Sai is Professor of Anesthesiology at AIIMS Patna, and Dr. Mayank Masand is Consultant Anesthesiologist at Indore. They both have been working tirelessly since many weeks, and I'm really proud of both of them. I'm happy to declare them as editors of the RSA newsletter, the RSA Times, and they will be working directly under the supervision of Honorary Secretary Dr. Vishal Singla and Dr. Swati Chabda, the Joint Secretary. This will be circulated on the social media along with the video and a message by the Honorary Secretary, and I request all of you to go through it and contribute to it also. Thank you very much. Long live RSA. I hand it back to Dr. Nishant.
Thank you so much, sir. Thank you for the guidance. Thank you for the encouragement. And we would, as editors, would like to thank everybody who has contributed to this issue. So coming back to the webinar tonight, sir, may I now request our patron, Dr. Tej K. Kaul, sir, for his views and for the session, or to start the session also.
Good evening, everybody, and a happy new year to all those who are present and each and every member of RSA. I am extremely pleased to be a part of the inauguration of the newsletter RSA, the RSA Times. I must thank the editors, Dr. Nishant and Dr. Manag, under the guidance of the secretary and the joint secretary. I am sure you have all worked very hard, and in the presentation of the newsletter, what I have seen as of now is really very impressive, very informative, and I am sure that it will make great headlines in the future. I welcome every member over here who is attending this webinar on intraoperative emergencies and which has been coordinated by Dr. Nishant and is organized by the RSA branch of Bihar Jharkhand branch. I am sure that under Dr. Nishant's leadership, Bihar Jharkhand branch is going to be a very important and the dynamic branch of RSA in future. Without wasting any further time, I request Dr. Nishant to please go ahead to start the webinar. All the topics are very interesting and they are all about the intraoperative emergencies, the day-to-day topics, which everyone will be very interested and will be very keen to learn new and refresh the memories. Thank you very much, Dr. Nishant. Please go ahead.
Thank you, sir. Thank you so much for the words of encouragement and the words of wisdom. And yes, not only are the topics very nice, we have some very eminent speakers also who will be delivering this lecture. But before we begin, sir, may we request the Treasurer RSA, Dr. Sunil Sethi, sir, to address the gathering on the new year.
Thank you very much, Dr. Nishant. Just hold on. Wish you all a very happy new year. And it's a pleasure to be here on the platform of RSA and releasing new newsletter of this new year. And I must congratulate Dr. Nishant and a whole of the team for the great work they are doing. Happy New Year to all, and thank you very much.
Thank you, sir. And before we begin, we must listen from our Secretary, Honorary Secretary, Dr. Vishal Singla, sir. A few words, sir, before we can start the webinar.
Sir, good evening, everyone. My regards to President Dr. Naveen sir, Patron Dr. Tejke Kaul sir, our Treasurer Dr. Sunil Sethi sir, and all the delegates present here. Thank you to each and every one of you for being here with us today. As you all know that Research Society of Anesthesiology has always been pioneer in promoting academics, and a proud moment for Research Society of Anesthesiology to launch this newsletter today. And I would like to take this opportunity to welcome you all to 34th National and 5th International Conference RSA Con 2026 at Indore. You all are kindly requested to mark your dates 10th to 12th April 2026 and join us in Indore for great academic sessions and for great Indori hospitality. Thank you very much. And also I would like to congratulate team Bihar and Jharkhand, Dr. Nishant and Dr. Nishant Sahay, to coordinate and arrange this wonderful and very apt webinar. Thank you very much. And Dr. Nishant, please.
I think,
Yes, thank you,
Nishant,
sir.
a few words from you and Mayank regarding your journey, a few words about launch of this newsletter. From the
Sir,
from the
first of all, I would like to really thank Dr. Nishant for taking a lot of pain with me because it requires a real amount of gel work sitting at two different places. Sir, your hard work and your dedication has brushed upon us. And at any point of time, your hand holding is always important for us. So thank you so much for that. Naveen sir. And yes, this edition, like we have launched few sections which will be constant in this news letter. And in this newsletter, we would like to stress upon the career part, difficult cases, and some general debate topics like any anesthesia can be given in many different ways. So a single technique can be good or bad for some patients. So it is you who choose what you do. So like that, we are going to frame up this issue and let's see how it goes further. With your blessings, it will go definitely to higher scales.
Yes, sir.
Thank you
Thank
so
you.
much.
And Dr. Mayank is
Dr.
taking.
Nishant, thank you for bearing with me.
Dr.
Sir,
Nishant.
Dr. Mayank, it is, the maximum work has been done by Dr. Mayank only, and he's actually
ऐसा
trying
कुछ
to
नहीं
break
है।
down. And I thank you, Dr. Mayank, and all of you. I mean, especially Naveen sir, who has been a constant guide. Every time we have had some issues, we've caught hold of Naveen sir, and he has guided us throughout
Yes.
from the word go. Obviously, there is scope of improvement, and we will definitely improve. And we will hope that the RSA web newsletter is an avenue for everybody to display their academic talent and non-academic talent also. Mayank Bhai has already mentioned there are a few segments which will be constant. We will be discussing and critically appraising one article which we believe will be an impactful article in the last two JOCP journal editions. There will be one statistical test that will be discussed in every issue, and likewise there will be many things that will be common in the issues to come. So hopefully we can do justice to the responsibility that you have reposed on us, sir.
God bless you, Nishant and Mayank. And I place on record the presence of our governing council members, Dr. Tanveer Singh, Dr. Parul Jindal, and the state representatives, governing council members, Dr. Lalit Regar, National GC member, Dr. Amit Kohli, and Shilpa Tivaskar. There are so many office bearers, Dr. Vishnu Mesh Babu. They have all joined from different parts of the country to celebrate the release of the newsletter. Uh, I a quick comment from Dr. Swati Chavda, Joint Secretary, uh, National Lead of RSA GOCP Editorial Fellowship Program.
Thank you so much, sir. A very happy new year to everyone, and congratulations to whole team RSA, from patron Dr. Tej Kaul sir, our president Dr. Naveen Malhotra sir, secretary Dr. Vishal Singla, the editors who are the backbone of the newsletter. Hearty congratulations, and it was wonderful writing for that in the inaugural issue. So thank you for the opportunity. And I welcome you all to this brand new year of RSA, which will be full of surprises and new activities coming up. So stay tuned and stay with all the activities, including the conference, annual national conference, RCP Con 2026 coming up at Indore. So see you there in person. And meanwhile, we will connect to our online webinars. Thank you very much and looking forward to today's session.
Thank you, Dr. Swati. Back to the Nishant to carry on the webinar.
Right, sir. So the first session for the day, the speaker will be Dr. Dev Sanjay Nag, sir. And Dr. Dev Sanjay Nag, sir, he's the consultant and head of Department of Anesthesiology at the Tata Main Hospital. He's a very, very good speaker with over 70 PubMed indexed publications. He's the president of has been the president of the ISA Bihar Jharkhand branch in 2019. He won the Kapil Dev Prasad Oration, and he won the late T.N. Jha Memorial Award and Dr. K.P. Chansoria Medal in 2006. He has been a faculty at most of the conferences. He is a very big name in Bihar and Jharkhand. He's been the organizing secretary ISACON East Zone in Jamshedpur, and won the B. Brown Medical Trust Foundation Scholarship Award in 2006. May we request Dr. Nag to please start his session, please?
Yeah, thank you, Dr. Nishan, for those kind words, and thank you everybody for the opportunity. So I'll just like to share my screen. Nisha, can you just allow me to share my screen?
Dr. Vishal, make the speaker's host, please.
Done, sir.
Okay.
Please share your screen, sir.
Yeah, I will just be possible.
Are you able to share? Yes.
So
Yes.
is the screen visible?
Yes, it is visible, sir.
Yes,
Please
yes.
go ahead, sir.
So again, thanks for the opportunity, and we'll be discussing a very little understood, I'll say, although all of us are aware, but most of us, and this has the understanding has been evolving over the years. So bone cement implantation syndrome. So I'll just start with how it may manifest with, God forbid it doesn't manifest. So this is just an example of a 77-year-old with a hip fracture undergoing a total hip replacement. And during the cementation of the prosthesis, the patient suddenly went into a pulseless electrical activity, and post CPR, the patient could be resuscitated. But we may not be as lucky every time, but we need to understand this, because vigilance is the key to actually understanding such occurrences which may happen. And obviously, there will be times when we need to be very, very careful and be alert. So, this is just the example of what potentially could have happened in this case. And this is a image way back from the Mayo Clinic proceedings, again reused in the British Journal of Anesthesia. So, what happens, what we are seeing in the echo is actually small emboli and small to medium size emboli and large emboli, which had happened during the cementation of the prosthesis. So this actually can be visible if we are at the same time doing an echo, but obviously the resuscitation and revival of the patient takes priority whenever we are faced with such occurrences. So bone cement implantation syndrome, there is actually no agreed definition. The first proposed definition came up in 2009 as a rare but potentially fatal perioperative complication, which occurs during orthopedic procedures involving the use of bone cement. But later on, we realized that even without the use of bone cement, actually similar syndromes can manifest. And it's primarily characterized by hypoxia, hypotension, and loss of consciousness. Although the intensity of each can vary with patient to patient, but the most unfortunate part is it can suddenly progress to a sudden cardiac arrest. So again, as I said, vigilance is the key. So before we go there, we just single slide on bone cement. This is actually polymethyl methacrylate. Basically, there are two. One is in the powdery form, and there is a stabilizer and a liquid which needs to be mixed. And obviously, there are substances which makes it solidify faster, and it can be used so that it is radio opaque also. So again, without going into the technicalities of what constitutes bone cement, we actually need to understand this syndrome so that we are able to actually understand whenever this happens. So fat, bone, and air cement monomers, they enter the venous circulation and ultimately end up in the pulmonary vessels. So this actually results in emboli, and most often observed during cementation. Continuous embolization is observed for quite some time because of the instrumentation. So emboli can be both direct mechanical obstruction or vasoactive mediator release, because these may stimulate histamine release and cause further aggravation of the pulmonary artery pressures. So uh, interesting fact is what we have seen is surgeons who are actually handling bone cement very often, they have their blood levels of C3A and C5A highest. These are actually anaphylactoid complements, and they actually precipitate reactions which can simulate a bone cement implantation like syndrome. So there is a set of population, I'm not saying the surgeons are who are handling the bone cement, they are more prone, but there is a set of population who will be more prone because they might actually be having anaphylactic substances in their blood. So one of the precipitants, and this is actually, this graph shows the pathophysiology of a normal circulation, how it happens. You can see the arterial trace also. And what happens is during the bone cement implantation and subsequent during the reaming and when the cement is being implanted, so it can potentially cause a flurry of emboli into the system, and they enter the systemic and subsequently the pulmonary vasculature and cause they affect what we now call as the bone cement implantation syndrome. But it is not only the embolic phenomena which is causing this effect, it is also a large number of patients. It actually, there is a histamine release also. As I said, there was anaphylactoid reaction also, which results in this syndrome. So these are some of the mechanisms through which the bone cement implantation syndrome can develop. So there are various models which suggest that this may be the cause. But to the best of everybody's understanding, it is actually a multimodal model which is the causative. It could be directly due to the effect of the emboli of bone cement. Even without bone cement during reaming, very high intramedullary pressures can result in such syndromes. Embolic phenomena, histamine release, complement activation, anything can actually cause this syndrome. So Donaldson was the first person in 2009 in British Journal of Anesthesia who graded this bone cement implantation syndrome into three grades. Grade 3 obviously is the most adverse, where there is a sudden cardiovascular collapse, as we saw in the index case initially. Grade 1 constituted of moderate hypoxia with less than 94% saturation and between 94 to 88, and grade 2 was less than 88. And or hypotension, which is more than 20% fall in systolic blood pressure, and 20 to 40 or more than 40 is grade 2. So this was the proposed definition, but actually the problem with this definition when it initially came up is there was no time frame about when the syndrome would develop. So subsequently, more research, more understanding of this syndrome has happened. And we also need to understand, with more and more joint arthroplasties and use of bone cement being common nowadays because of the longevity and more prosthesis being implanted. So we are seeing more and more such cases. The incidence may have remained same, but because a large number of such procedures are being done, we are seeing slowly more and more such cases. So in 2005, basically the same British Journal of Anesthesia again came up by modifying that. They proposed that there should be a time frame to actually, when we say that it is bone cement implantation syndrome, it should be from the time of reaming to prosthetic implantation to cementation and up to the skin closure. Because beyond this point, various anesthesia and patient related factors can actually result in similar syndromic issues. So this is the definition which BJ has said in 2025, but there are hosts of other case reports where which say that there is a case of delayed onset bone cement implantation syndrome also, which has developed 1 hour post-operatively. And if we look at the CNS symptoms, because either there is a patent foramen ovale or particulates of the cement and managed to pass through the pulmonary vasculature. So CNS symptoms can also develop much later. So actually there is still not much clarity, but we will go by the definition which actually specifies that directly from the reaming to skin closure, if there is this syndrome developing, that we define as the bone cement implantation syndrome. A very interesting thing which has come up over here is we are saying that there should be a relative change in MAP, because what happens is there is a established definition of hypotension which is MAP less than 65. Because we know that between 65 and less than 55, there is actually end organ damage and renal outcomes are poor. So there is a definition of intra-op hypotension. But to define bone cement implantation syndrome, this new paper of 2025, they are saying that there should be a systolic blood pressure of more than 20%. And in 2025, they have modified it from 20 to 15% and 15 to 30% and beyond 30%. So there is a marginal change in the fall in blood pressure, but the difference is there should be a fall of more than 15 to 20%. And it is not only a map, a particular number which defines bone cement implantation syndrome. So these are the various parameters which can get impacted. So there are various publications which have shown that some of the parameters have changed. So obviously we expect a increase in the heart rate, a decrease in EtCO2, a decrease in PaO2, a MAP decrease which we spoke of, and an increase in mean pulmonary artery pressure also. So there are various publications to this effect. And this is just a graphic representation of the timelines when this actually develops. So the same parameters, the heart rate will increase and then start dropping, leading to a sudden arrhythmia also. Same happens with the hypotension, and the ultimate would be cardiac arrest. So there are actually in PubMed two reported cases of death from a corporate hospital in India. So not that it is very uncommon. Obviously, adverse outcomes generally we don't report as case reports or otherwise, but incidence wise, people who have centers which have good repositories of the outcomes, the averages are coming out from those institutes. So as I was talking of, there are cerebral complications also, which can result in a long-term cerebral hypoxia, stroke, seizures, and confusion. Many of them may manifest at a much later time. So the immediate syndrome, what we saw as decrease in saturation and blood pressures, that can happen immediately, but long-term also sequelae can happen. So it does not fit into the very strict definition, but these are some of the implications which can happen at a later point of time. And incidence, see, obviously the higher grades, the incidence is lesser, but lower grades, it is common. And if we look at the subtle signs of the CNS signs, so it could be possibly higher. And obviously, the higher grade, the mortality, 1 year mortality is very, very high. But still, even if it is a grade one, there is a long-term 1 year mortality of approximately 25%. But as anesthesia is becoming safer, by the day, this is also coming down because we are getting more aware of what is in store and how to be prepared for such. And as I said, there have been case reports with bone cement implantation has happened with uncemented arthroplasties also. So this is just the odds ratio of the comorbidities which are possibly there, because obviously the higher ASA grade, COPD, use of diuretics, warfarin, these all increase the possibility of BCIs. But factors like atherosclerosis, cardiac congestive heart failure, beta blockers, ACE inhibitors, these are actually not predictive of BCIs. Now, what has happened is the University Hospital at Coventry, they have come up with a beautiful concept of a cement curfew. And this is basically while you are putting in the bone cement, there should be a discussion between the surgical and the anesthetist team, identify cases which require cement curfew, and the team brief actually discusses that. And the end of the timeout, they assign roles to the theater staff. And basically, there is a higher level of alertness of if this bone cement implantation syndrome might occur. So if occurs, what happens is the lead anesthetist ensures that the team is aware, and subsequently, obviously, the resuscitation part kicks in. So this is one good concept possibly institute centers can look at adopting, because this can actually save lives. So these are some of the methods which have come up to prevent bone cement implantation syndrome. So, and there are some surgical techniques also which decreases incidence, like a pulse lavage, use uh, suction catheters to depressurize the canal. So obviously these are surgical techniques which decreases the incidence. And for resuscitation, obviously the first thing always is give 100% oxygen, fluid resuscitation, vasoactive drugs, and ensure that there is adequate resuscitation and we are able to revive the patient. These are just some studies which says that the cemented hip arthroplasty, the incidence is between 50 to 40, 15 to 40%. Various studies, and this is from Dr. Bhadani. I think Dr. Nishant and others would be knowing it. So the first study reported in the BJA article which has come up is from our own state, which we are presenting. And the, it is also common, sorry for the overlap in the text because it's not opening in PowerPoint, but I think we can make meaning out of it. Even in uncemented, the incidence has been reported to be between 0 to 21%. And patients with malignant disease, the incidence is much, much higher. But obviously, as I said, very few of the adverse outcomes get reported unless we have very large repositories of data reporting and looking at it retrospectively, what is the mortality. So while we know that it can happen with total knee arthroplasty, shoulder arthroplasty, but there are no studies actually showing the incidence. And now with the starting of vertebroplasty is also in a big way, large number of cases undergoing vertebroplasties with bone cement. Even the incidence of bone cement implantation syndrome with vertebroplasty has also increased significantly. So the risk factors are obviously increase in age, ASA status, cardiac comorbidities. There are surgical factors also, like a normal hip replacement due to osteoarthritis, and compared to a fracture surgery, the incidence is much higher. The technique of the surgeon, like the cement pressurization, also increases the risk. There are high risk patient groups also, like elderly, patients with impaired RV function, and as I said, patients with fractures also. And the long stem component use also has been seen to increase the risk. So what do we do? Basically, first thing is early recognition. And as I have been stressing on repeatedly, vigility is the key, and early recognition before a hypoxia, even a fall in entitled CO2 could alert you much earlier. Development of dyspnea, altered sensorium, oxygen saturation changes, blood pressure fluctuations before it actually starts dropping. So these can be actually good early recognition signs for bone cement implantation syndrome. The management is basically standard resuscitation protocols only. There is no particular antidote per se. So immediately increase the oxygen, aggressively fluid management because to resuscitate the patient. And in some cases, we will need inotropic drugs also to support the patient. Basically, if we are able to do a cardiac output guided therapy, the outcomes are expected to be much better. But the incidence is so low that any such study about cardiac output guided therapy in bone cement implantations we have not had as of yet. So coming to the management part of it, say management apart from the clinical management, the coordination between the team, the coordination between the surgery, the surgeon and the anesthetist, debriefing after the incident, recognition of the high risk period when actually these patients are susceptible, monitoring at a higher level, basically of alertness, vigility, and a coordinated response protocol, like we saw as the bone cement curfew period being used in some of the institutes. Sorry, this slide is not visible because of similar reasons. But again, a better monitoring at that point of time can actually improve outcomes. And post-operative consider, obviously, as I said, although strictly by definition, we say it is from the reaming or the bone cement implantation to the skin closure time, but post-operatively, many of these patients, especially if there is a patent foramen manual, it can lead to cognitive, it can lead to long-term, yeah, issues with the central nervous system also. So monitoring into the post-operative period is also as important. We are not very sure what is the cause, but we know that in geriatric patients undergoing hip replacement, there is a higher risk of delirium. Whether this is a causative reason or not, studies have not been able to prove as of yet, but a neurological evaluation and a long-term follow-up later on, I think, will be helpful. So the future research obviously will be in the direction where we can actually look at defining such cases, and with more and more such arthroplasty surgeries happening, we will face more such challenges. But the surgical techniques are also getting modified. So there is always a effort from the surgical team as well as from the anesthesia team to minimize the risk and improve the outcomes. So the key recommendations basically, please do identify the high risk patients, implement monitoring, especially during the high risk period when the cement is being inserted and the implant is being inserted. A good communication between the surgical team, because many times the patient is on the other side of the drape and the anesthesiologist may not be aware of what is happening. So a good communication and apply the prevention strategies. And obviously, the next part is to ensure a rapid response. So this was in brief about bone cement implantation syndrome. The topic is still being understood and more knowledge and information on the subject is coming up. So thank you so much for the opportunity. Thank you, everybody.
Thank you so much, Nag sir. I understand 15 minutes is not enough for discussion of a topic like this. Uh, with permission of the honorable chairpersons, what we can do is we can take all the questions after the session. And to introduce the next speaker, Dr. Ashok Jadon, sir. Dr. Ashok Jadon is again a doyen in the field of anesthesiology from Bihar, and he's basically from Jharkhand. And he is currently at the Meherbai Tata Memorial Hospital, Jamshedpur. He has his own Jadon Pain Relief Center. He is a very well-known figure in pain management and regional anesthesia. His areas of interest include interventional pain management, cancer pain management, ultrasound guided blocks, and he has more than 100 national and international publications and many chapters. So to discuss the next topic on the effect of on one of the adverse effects of regional anesthesia, uh, seizures or fits after a brachial plexus block, I think there could be no better person than Ashok Jadon sir, who has been a teacher to many people in our state. Sir.
Yeah. Am I audible?
Yes, sir.
Good evening, dear colleagues and respected seniors, all the family of RSA. I'm going to present a not very uncommon problem during anesthesia, particularly regional anesthesia, that is the seizures during brachial block. So allow me to share.
You will be able to share, sir.
Yeah, is it visible?
Yes, sir. Just presentation mode, please.
Yeah, it is in the presentation mode.
Perfect, sir.
Yeah. So good evening, one and all. As we all know that brachial plexus block is a standard regional anesthesia technique for the upper limb. Many local anesthetics like ropivacaine, bupivacaine, levobupivacaine being used to use this technique. And main approaches are interscalene, supraclavicular, infraclavicular, and the axillary blocks. There are many others, but they are the four major techniques which we use. But what is interesting, as in shown in this particular diagram, that whatever approach we may choose, there is always a possibility of local anesthetic tracking to the blood vessels, because all the nerves also passes very near to the blood vessels. So primarily these seizures are supposed to be a local anesthetic systemic toxicity or the last, and this happens when the threshold for the seizure crosses in the blood which is carrying the local anesthetic. The cellular mechanism proposed one is that the local anesthetic binds with the sodium channel, make it refractory, and this refractory period is more effective on the inhibitory pathways rather than the excitatory, which causing an imbalance and resulting in dominance of the excitatory pathways and thus causing the seizures. It is not only the sodium channel. Local anesthetic also binds with the calcium, potassium, and the GABA A receptors, also causing the exacerbation of the excitatory pathways. The causes are primarily inadvertent intravascular injection, which can happen when the large volume is injected directly into the vein accidentally, or even a small amount if it is injected into the artery, particularly as we see like in vertebral artery, which is present in the area of the interscalene block, can result in the seizure or convulsion. Or there may be rapid systemic absorption, which is seen when we use a large volume in particular supraclavicular area. Then the slow absorption or the fast absorption can happen from that area, which is a very vascular area, and can lead into seizure. There may be absolute overdose. All the local anesthetics being suggested a safe dose, but by miscalculation or by accident, if we use large doses, there is always a propensity for the seizure to occur. And then use of excessive dose. In this situation, though we are using an standard dose, but this standard dose is actually maybe little more for a susceptible patient seen in the malnourished patient who are having the low albumin level or uremic or epileptic patients. So there are certain anatomical and technical regions which may lead to seizure, like block location. The risk of seizure is very significantly through the approaches, like we have seen the interscalene blocks have the highest incidence, approximating about 7 to 8 cases per thousand. Contrast to that, the axillary block has the least, where the 1 or 1.2 cases per thousand been reported. And this difference is primarily because the major arteries or veins in the area of interscalene area, and also the accidental intrathecal injections are much more in the interscalene area. That are the two primary regions. And also the technique which we use, like whether we are using landmark guidance or ultrasound guidance, though it is not a direct correlation with the occurrence of the seizure, but as we can understand, the absence of real-time ultrasound monitoring increases the likelihood of the puncture of vessel and causing the seizure. There are certain patient associated risk factors. They are, like suppose patient is having pre-existing epilepsy, they have a lower threshold for seizure. And similarly, like a patient is already under having metabolic derangements like hypoxia, hypercarbia, or acidosis, the seizure threshold is decreased and they are very prone for the seizure to occur. Age and health status, extreme of the age, and if patient is having liver or kidney disease, are definitely having the high risk of seizures because of slower metabolism or the lower clearance of the drug. There are two types usually: the early onset, which usually seen when the inadvertent intravascular injection is given, and there is a slow variety, like when there's a delayed onset, which may happen maybe up to after three or more than 3 hours. This happen when the drug is slowly absorbed, where the injection site working as a pool, and the drug is slowly absorbed and crossing the seizure threshold. But what is most important is to remember whether it is an early onset or late onset, it is always mostly associated with prodromal or the warning signs, where patient starts complaining of perioral numbness, metallic taste, tinnitus, agitation, and we may notice the slur disease. So this is the actual time where we can predict that this patient is going to have seizure. Seizures are mostly of three types. It may be a generalized tonic-clonic seizure and associated with loss of consciousness. And remember, this is the commonest type of seizure during after the brachial plexus block. There could be a focal seizures where the twitching, local twitching is seen, but there is maybe little change in the consciousness, but patient never lost full consciousness in such situation. Or third variant is, which is the rarest, is the status epilepticus, where seizures are long lasting more than 5 minutes, or there is a recurrence of the seizure without the recovery. So what is the diagnosis? Diagnosis, there is no definitive diagnosis. It is a clinical syndrome, but always have a temporal relationship. Like we have used the brachial plexus block and patient is having seizure. So this is enough to predict and diagnose that patient is maybe having the local anesthetic associated seizures. There may be other syndromes may mimic uh, seizure because of the local anesthetic. They are the hypoxia. If patient is having some inadequate ventilation because of our sedation or some airway obstruction is there, then hypoxia can cause the seizures. Vasovagal syncope, sometime patient lose consciousness suddenly, and but this can easily be differentiated from the seizure because of the local anesthetic, that this usually happen even before we have injected. So there is no temporal relationship. But hypoxia or vasovagal syncope, they are not the helping you to diagnose, but rather giving a differential diagnosis that this particular seizure is not because of the local anesthetic toxicity. There may be total spinal anesthesia, particularly when we use interscalely and accidentally we have gone into the spinal space, and the sudden loss and jittery movement can mimic the toxicity of the local anesthetic. The other diagnostic cues may not be diagnosis for the why the seizure has happened, but suppose some patient is having associated cardiovascular instability, this is an important cue that this is the part of last and patient is going to have the cardiac arrest or some cardiac instability. And this precedent of this cardiac instability is definitely seizure, and it definitely will be of local anesthetic. Laboratory test, this is always, you can say, done to just rule out the cause of local anesthetic toxicity rather than prove it, where the arterial blood gas or electrolyte level may prove that it is either because of the hypoxia or acidosis these convulsions might have occurred. Yes, post-seizure imaging definitely of help when there is a persistent neural damage. It can rule out, like MRI or neurography can rule out that there is no cortical injury or cortical injury is present. But whatever is happening, most important part is to remember that we do not wait for the diagnosis or looking for the cues. We have to start the treatment, because missing out on that particular moment is definitely going to do a patient will go into the severe cardiovascular instability and maybe the cardiac arrest. So what are the precautions to avoid all these? First and foremost, to minimize the local anesthetic use and to use the lower most effective dose. Also use the ultrasound guidance where we can see our needle nicely, and also a spread of local anesthetic. And if the local anesthetic spread is very decent with a small amount, definitely we are going to use a small amount rather than the full dose prescribed dose we are going to use. And also, wherever possibility, use the color Doppler. As you can see in this diagram, interscalely, we are seeing a very beautiful spotlight pattern of the three nerve roots, and thinking that uppermost is the 5, but when we start Doppler, we are surprised that it is not C5, rather than an artery sitting over there. And also use the incremental techniques, like whatever amount of we are going to inject it in small aliquots every time, aspirate before the next injection. And if you are using like norepinephrine or epinephrine, not norepinephrine, epinephrine in the solution, this gives you an early warning sign by increasing the heart rate and the blood pressure that there is an intravascular leakage of the local anesthetic. Like choosing the anesthetic, type of anesthetic is also very important, because it is seen, like it was taught to us, that bupivacaine is less safer for the cardiac instability than the ropivacaine and levobupivacaine. But now this is also seen for the neurological safety also. Ropivacaine and levobupivacaine have an edge over the bupivacaine. So wherever we have chance, always choose the Rupiva or levobupivacaine than the bupivacaine. Monitoring is very important, because patient should be monitored at least for 30 minutes. As we have seen, the onset may be delayed for at least 3 hours. So monitoring for 30 minutes is vital for every brachial plexus block. And this also gives you an opportunity uh, to observe the early warning signs. As we have already discussed, patient starts complaining of periolar numbness, or there is a change in tone or quality of voice, gives an early warning that patient might go into the frank seizure, or later on maybe to the cardiac toxicity. The other preventive measures has been suggested about the needle and the gauge and type of needle. So what is recommended, that if you use short bevel needle, particularly ecogenic, if you are using the ultrasound, 22 gauge, which is moderately a good size, neither very fine, where we can miss out the puncture of the vessel, not very large, where even if we puncture the vessel, a lot of damage of the tissue to happen. So 22 gauge, and using the tangential approach for the block, not perpendicular over the vessel or over the nerve, can help to prevent these complications. Now the management. The what is most important is the promptness in the management. So prompt action is required, and that is start with the securing the airway, giving 100% oxygen. As we know, it may not be the local anesthetic toxicity, but the hypoxia is a big contributor. So correcting it is also important. And convulsion can be treated with benzodiazepines, either midazolam 0.05 to 0.1 milligram per kg, or lorazepam 0.0 to 0.05 milligram per kg, to terminate the seizures effectively. A small dose of propofol can be used, but it is debatable. If vitals are stable, definitely you can use a small dose of propofol. But if vitals are not stable, it is better to be avoided. And General anesthesia, though it is rarely required, like a situation of status epilepticus, we may require a general anesthesia to control the seizure activities. What the most important, the lipid emulsion therapy. Initially, it was thought that the lipid will be working only for the bupivacaine and the type of that long-acting anesthetic. But now, even in the lidocaine toxicity, lipid emulsion has to be used. And all the present guidelines recommend the use of lipid emulsion earliest possible. So the doses for that is 20% intralipid. The first bolus to be given 1.5 ml per kg over 2 to 3 minutes. And then subsequently, you have to start 0.25 ml per kg of infusion. And maximum you can go up to 10 ml per kg over 30 minutes. Also, never forget our ABC, we have to support the airway, use the benzodiazepines to control the seizure. But what is recommended that do not use very high dose of epinephrine in the vascular instability, and vasopressin should be avoided. So there are, what are the key points in the seizures of the brachial plexus? It is not rare, though uncommon. The incidence is approximately about 0.08%. But what is important that if you miss or you delay the management, there is a fatality which could amount to 0.01% also. The seizure risk is high in the interscalary and supraclavicular block. Reason I have already explained, because of the proximity of neuroaxis and the high vascularity in those areas. And identified causes of the fatal outcome have been reported are when a large dose of intravascular accidentally we have injected, or there is a total spinal anesthesia, like in interscalary, and accidentally we have touched the root, which is the cover of the root, which are directly going to the spinal cord, and we may miss, and then later on the total spinal anesthesia can happen. Or the unrecognized toxicity. As we all know, the blocks sometime mixed up with the general anesthesia as a combined therapy, GARA, where the general anesthesia is combined with the regional anesthesia technique. And we do not wait for the effect for 30 minutes or what is recommended. We immediately go for general anesthesia. In that situation, we may miss the early signs and we can land up into the severe toxicity and even death. And the last but not the least, wherever is the doubt, use the intralipid, because use of intralipid will not kill the patient. But missing out on the toxicity and delaying the use of intralipid definitely may kill the patient. Thank you. Thank you very much.
Thank you, sir. Yes. Thank you, sir. That was a very lucid presentation, and I'm sure a lot of people who are listening to this talk will have their own experiences also. And in the meantime, I would encourage all the audience members to also ask any questions they might have in the chat box. We will discuss it at the end of this session. So, with permission of the chairpersons, we would like to go ahead with the final talk. And to deliver this final talk is one of the young guns, Dr. Pradhan MN. And we are especially proud of him because he's done his post-graduation from our place. He's currently a specialist at the Krishna Institute of Medical Sciences, ECT in Bangalore. He has a special interest in pediatric anesthesia and POCUS. And I can personally vouch for the fact that he is a super anesthetist and a very, very good team player, somebody we would want always to be on our side of the team. And it is very nice to see you, Pradhan, and hope just one small request, we are running a little low on time. So there's another very important RSA editorial fellowship class coming up after this. Dr. Swati is looking very keenly at the classes, so we'll need to finish it on time. Okay, Pradhan?
Okay, sir. Okay, sir.
Ciao. Start.
A very good evening to all the respected faculty who have logged in onto the RSA class for today. And I'd like to thank Dr. Nishant sir for giving me this wonderful opportunity to present at a national stage. So I'm Dr. Pradhan. Today I'll be talking about the case regarding desaturation after extubation in a pediatric patient. So the content for the upcoming case is as follows. So I'll be discussing about the case history, how the case was managed perioperatively, two main causes for the desaturation in a child post extubation would be laryngospasm and bronchospasm, and hence I would like to discuss the management aspects of both the scenarios. So, in my case, there is a 5-year-old child who presented with swelling in the neck region since 2 days, and it was associated with fever, cough, and poor feeding. So the child was diagnosed to have submandibular abscess based on the clinical and the USG findings. And hence, on an urgency basis, the child was posted for incision and drainage for the same. So pre-anesthesia checkup showed the history of active URTI, which was probably the cause for the abscess. And this patient was taken up for surgery under risk of post-operative respiratory adverse events, the PRAE complex, in view of the urgency of the surgery. So intraoperatively, the patient was given general anesthesia and managed with an LMA airway device. The surgery went uneventful. The patient was extubated on table, and post extubation, the saturation rapidly fell to 70%, and there were no chest movements at all. So, what's the diagnosis? So, in any case of desaturation post extubation, in either in an adult or a pediatric patient, we should always keep the 5 main provisional diagnoses in mind. The first is the bronchospasm, the laryngospasm, an obstructed upper airway due to excessive anesthetic agent, or an obstructed airway due to inadequate reversal or non-contractile muscle, and respiratory depression secondary to drugs, anesthetic drugs like opioids. So the most important dreaded complication that we see in the pediatric age group post extubation is the laryngospasm. So moving on to the basic aspects of laryngospasm. So laryngospasm is defined as an exaggerated maladaptive glottic reflex. So the pathophysiology behind is that whenever there is airway instrumentation or any noxious stimulus uh, in during the light plane of anesthesia, there will be stimulation of the glossopharyngeal and vagal nerve. So this will result in the discharge of the vagal nerve, which will result in the spasm of the entry of the glottis, that is the adductor spasm, and it will, in severe cases, it will be associated with the descent of the epiglottis over the larynx, completely shutting off the airway and protecting the lower airway from entry of any secretions. So it's a protective reflex. Whenever it's exaggerated and maladaptive, it results in laryngospasm. So, what are the risk factors for laryngospasm? Laryngospasm risk factors include anesthetic risk factors, patient risk factors, and as well as surgical risk factors. So, the anesthetic risk factors include light plane. So, whenever there is airway stimulation or suctioning or extubation or intubation or insertion of oral airway in light plane. Second is the pungent usage of pungent inhalational agent such as isoflurane and desflurane, and isolated usage of ketamine and thiopentone. We all know that there is no active suppression of the airway reflexes whenever these agents are used. So isolated use will result in unnecessary, will ensure that there is active nerve discharge, which will result in spasm. Usage of any invasive air device, that is the LMA and endotracheal tube. Although endotracheal tube will have a more severe response and may increase risk of laryngospasm. The next factor would be blood and secretions in the airway, which is either caused due to trauma externally or due to trauma during our laryngoscopy. The patient's risk factors are as follows. The pediatric age group, there's more risk when it comes to the infancy when compared to the older children, and the risk reduces as the child ages. Any recent URTI. So any recent URTI is defined as a period of URTI, active URTI and post URTI within 2 weeks. Any reactive airway disease, that is the patient is a known case of asthmatic, any in the history of smoking, that is in the case of a child it would be passive smoking. Then another risk factor would be airway anomalies, that is congenital anomalies of the airway. The third the third aspect is the surgical factors. Whenever there is the surgery conducted on the airway, all the ENT and neck surgeries, and whenever there is visceral stimulation, so this includes all non-airway surgeries like cystoscopies, and draining of the peritoneal fluid, draining of the pleural fluid. So how do we diagnose the case of laryngospasm? So laryngospasm is the most dreaded complication that you can see post-extubation. So and any patient of laryngospasm will not give you much time. So you have to pick it up within 10 to 20 seconds to ensure that it is adequately treated. Otherwise, whenever there is laryngospasm, the patient will rapidly desaturate, there will be minimal chest movement, and there will be severe tracheal tugging, which can result in negative pressure pulmonary edema, rapid desaturation, cyanosis, and in children, whenever there's desaturation, it will be associated with bradycardia at an early stage, and the child can collapse. So always pick up the, sorry. So always pick up the laryngospasm at an early stage. So how do we prevent it? Now that we have diagnosed this child to have laryngospasm, we should know about the theoretical prevention aspect and as well as the treatment aspect. So how do we prevent it? So there are two ways to prevent it. One is the anesthetic measures and the other the pharmacological measures. So the anesthetic measures are as follows. So the usage of non-pungent inhalational agent and maintaining adequate depth prior any airway instrumentation or prior any surgical stimulation. And whenever you suction, the patient has to be in a deep plane of anesthesia, especially during the time of extubation. And giving positive pressure ventilation just prior extubation. So what happens in a so whenever there's a patient with who's intubated, the endotracheal tube cuff holds all the secretions in the larynx and prevents its entry into the lungs. So just prior extubation, if there is no positive pressure provided, immediately post deflation of the cuff, all the secretions are going to enter into the airway and stimulate the airway unnecessarily and cause a severe spasm. So the best way to prevent would be to routinely use positive pressure ventilation just prior extubation. So what it does is, so how do we give positive pressure ventilation just prior extubation? We put the machine on the manual mode, set the valve to 20 centimeter of water pressure, and then hold the bag just prior deflation of the cuff. And this will help us in two ways. So first is that there is a positive pressure created within the trachea, which will splint the vocal cord physically. Second is that because of the positive pressure created, all the secretions are spurted out into the pharyngeal region in the hypopharynx, where it can be easily swallowed by the patient. And this will prevent the entry of the secretions into the air. One more preventive method would be to extubate the patient in deeper plane. The other technique is usage of no-touch technique for extubation. So in no-touch technique of extubation, the suctioning is done in the deep plane, followed by which the patient is put in lateral position and no further suctioning is done. And once the patient is fully awake, the patient is extubated. And to make sure that we are always prepared for any kind of emergencies, we always have to load propofol and succinylcholine in a separate syringe and keep it in the drug tray for all the high risk cases where you expect laryngospasm to occur. Moving on to the second aspect of laryngospasm management, which includes pharmacological measures. So we have to give IV lignocaine. So the dosing is 1 mg per kg. So when do you give it? 1 to 2 minutes prior extubation to suppress the reflexes. Second method would be to apply lignocaine topically on the cuff prior intubation to anesthetize the vocal cord and the part of the airway which might get stimulated during the intubation process. The third treatment would be the preventive step would be to give magnesium sulfate IV 15 mg per kg around 2 minutes prior extubation, again to suppress the reflexes. Anticyalogog, that is glycopyrrolate at a dosing of 3 to 5 mics per kg IV prior intubation, results in reduced secretions. And this anticyalogog effect lasts for around 4 hours. So you can give it, and the onset is around 20 to 30 minutes. So you can always give it prior intubation to reduce the secretions. So that was the most important aspect. How do you treat once the laryngospasm has happened? So you always stop the stimulus. So you always stop the surgical stimulus or the airway handling that you are doing. That is, your oral airway is in the mouth, or your the laryngoscope is being actively maneuvered. So first is to remove it and increase the oxygen to 100% and apply a positive pressure. So CPAP is applied for around 15 to 20 centimeter of water. So how do you apply it? You hold a mask, you put it on the manual mode, say, or in higher end machines you can go for a direct spont mode, and keep a pressure of 20 and give and open up the airway with the triple maneuver by giving the jaw thrust and neck extension, and so that the airway is made patent. So this will result in positive pressure, which will act as a splinting agent and physically separate the vocal cords. And simultaneously, while you are opening up the airway, you can also apply the Larson's maneuver. So what exactly is the Larson's maneuver and why it is used in laryngospasm? So Larson's maneuver is application of a painful stimulus at a Larson's point, which will induce a braking effect on the stuck vocal cords that is stuck due to the spasm. So where do you apply it? So you apply it at a point that is bounded by superiorly by the skull base, posteriorly by the mastoid process, anteriorly by the posterior border of the ascending ramus of the mandible. So whenever you are giving the jaw thrust and opening up the airway, that can be done with the index fingers in a child, which is a small size. So simultaneously, you always use your middle finger to provide a painful stimulus at this point exactly. And you once the pressure is applied, it's for around 5 to 10 seconds. The pressure is relieved while maintaining the jaw thrust. So this will help in breaking the spasm. So once all these steps are done, you assess for the severity of the spasm. If is an incomplete laryngospasm, that is, there is partial chest movement, previously there wasn't, now we have to deepen the plane of anesthesia. So since there is partial laryngospasm, that is, the cords are slightly open and there can be air entry, we can use a inhalational agent and a low dose of propofol. So propofol is used as at a dose of 0.5 mg per kg. If there is complete laryngospasm, that is, there is no chest movement at all and it is as severe as it was before, then definitely have to go for an induction dose of propofol and start our routine positive pressure ventilation. And with this, usually with this second step, usually the laryngospasm breaks. If it doesn't, again, if it is persisting, then the third step would be to go for a muscle relaxant to completely relax the cord. So laryngospasm can happen anytime before the induction of during the induction of anesthesia or post extubation. So it is not always that you have a cannula secured in a pediatric group. So if you have a cannula, that is, whenever you are extubating the child and there is a laryngospasm, then you always go for a muscle relaxant. Remember, succinylcholine has to be only used as an emergency drug in the pediatric age group. It is not meant for regular muscle relaxation during intubation. It is only reserved for such emergencies where muscle relaxation is required. So the dosing is around 0.5 mg per kg. Usually the dose ranges is mentioned in 0.25 to 0.5, although Barash Southeast Asian mentions around 1 to 2 mg around 1 mg per kg. You can always go for a moderate dose range of 0.5 mg per kg. Or if there's contraindication to succinylcholine, you can always go for rocuronium of 1.2 mg per kg IV. If there is no IV access, that is, your laryngospasm occurred during the induction, during the securing of the airway, then the only option would be IM route. So here the dosing will be 3 to 4 mg per kg or 1.4 mg, 1.8 mg per kg rocuronium. So that completes the laryngospasm. So regarding this case discussion, so the child rapidly desaturated and there were no chest movements. So the child was diagnosed with laryngospasm and then CPAP was given and which broke the spell of the laryngospasm and we were able to ventilate the child. So moving on to the next common cause of desaturation post-extubation, that is the bronchospasm. So bronchospasm can be diagnosed, as you all know, with the basic clinical parameters and ventilatory parameters. That is, there'll be a high airway pressure, reduced tidal volume, definite desaturation, but not as rapid as laryngospasm. So you definitely have some amount of time to diagnose the bronchospasm, and there will be definite audible wheeze due to the constricted bronchioles. And slowly, when the severity of the spasm worsens, there will be upsloping of the ATCO2 waves. And this is typically called as the sharp fin waves. And once you have picked up the diagnosis of bronchospasm, it is always better to rule out the occurrence of anaphylaxis. But as we all know that anaphylaxis can be a very dreaded complication due to any cause during the perioperative period, and it is usually associated with the bronchospasm. And simultaneously, you also rule out other causes of high peak airway pressures and desaturations, which includes the kinking of the ET tube and presence of ET secretions, which block the airway. So how do you, what are the preventive measures? So under the bronchospasm management, we have to know about the preventive measures, because many preventive measures help us in ensuring that delaying or preventing bronchospasm completely. So the first one is to optimize all the airway diseases the child has. That is, usually children with asthmatic who are uncontrolled will go for increased risk of bronchospasm. If there is URTI, then delay the surgery for ideally 4 weeks, because even after resolution of the URTI, the airway still remains reactive. So there can be increased risk of bronchospasm. So you always delay the surgery for at least 2 to 4 weeks once the URTI has settled, not from the date of onset of the URTI. Then the third step would be to avoid passive smoking. And the other anesthetic preventive measures include performing extubation at deeper plane so that there is not much stimulation of the airway. And also usage of, also avoiding the use of pungent inhalational agent. The most common method of prevention would be to give the nebulization of bronchodilators, that is short-acting, muscarinic, anti-muscarinic, and also using of beta-2 agonists. So when it comes to the pediatric age group, we should be aware of the adequate dosing. So how is it dosed? So salbutamol nebulization is dosed at 0.15 mg per kg, but there is always a minimum dose that you have to provide, that is 2.5 mg. So whenever you the most important practical aspect whenever you give nebulization to a child is that make sure that the total nebulization volume in the nebulizer mask is 3 ml. So how much ever salbutamol you take, make sure you add a saline to make the total volume of 3 ml. So for a 20 kg child, for less than 20 kg child, the dosage of salbutamol is 2.5 mg, and above 20 kg it is 5 mg. And this is the same for the adults. For ipratropium dosing, for less than 20 kg, the dosage is 0.25 mg, and above 20 kg is 0.5 mg. So make sure you keep the total nebulization volume at 3 ml. And so when do you have to give it? So you have to give it ideally at least 15 to 30 minutes prior the intubation process. So before shifting the patient to the OT, so we give the nebulization to the neb mask, and just prior extubation, around 15 to 15 minutes prior, we give the salbutamol or ipratropium or both via the pressurized meter dose inhaler, the MDIs. So how do we treat the bronchospasm? So there is a arbitrary classification of bronchospasm into mild and more severe. So mild is when there is desaturation up to 90% and there is enough time to manage the above mentioned condition. Severe is when the desaturation is more rapid to less than 90%. So in case of mild bronchospasm, we always have enough time to deepen the plane of anesthesia and cause the bronchodilation with the available anesthetic agents. And here, since the airway is not collapsed entirely, there is a role of usage of inhalational agent to bronchodilate and deepen the plane. You can also definitely use propofol, which would be a better option. If persisting, go for the meter dose inhaler usage, that is the salbutamol. So salbutamol MDI comes as around 90 to 100 mics per puff concentration. So what is the dosing in a pediatric group? So the references will take come from the up to date regarding management of perioperative spasm, also including the asthmatic patients. So they mentioned the dosage of around 22.5 to 30 microgram per kg, minimum dosage being 360 microgram, maximum being 720 microgram. So if you consider a 90 microgram per puff, so that comes to a dosage of 4 to 8 puffs. So in order to dose it,
I just I'm very sorry to interrupt you, but we need
yes,
to finish it a little bit earlier. है ना, Pradhan?
yes, sir. I'll just wind up.
I'm sorry. Yeah.
Yes, sir. Sure, no problems. So the dosing is as follows: less than 10, 20, 20, more than 20 kg, 4, 6, 8 puff. And how do you give it? You give it so that you attach it to the face mask, the anesthesia mask, and deliver 4 to 6 tidal breaths and hold the breath for around 5 seconds. If it's an endotracheal tube that we are using to deliver the agent, then you add on 2 to 3 extra puff, because small amount of agent will remain in the endotracheal tube. So most important to handle the MDI prior using it, you always have to prime it. And how do you prime it? Whenever you have to prime it by shaking it and spraying it 4 times. So this is the most important aspect whenever you are using an MDI for any use. And in case of severe bronchospasm, there are IV medications. That is the usage of glycopyrrolate to reduce the not to reduce the secretions, but to bronchodilate the patient. This will last for about up to 4 hours. And usage of ipratropium is added on, which comes as 20 microgram per puff, and number of puff dosage is similar to the salbutamol. If asthmatic, then only you add on systemic steroid, either in the form of methylprednisolone or dexamethasone. And if asthmatic is not responding, then you add on in IV magnesium sulfate. Popular to and the steroid use and magnesium sulfate use was only in asthmatic patients, and there is no role of inhalational steroid in non asthmatics. So there is no use of Budecort in a routine bronchospasm where asthma is not a cause. So thank you, everyone.
Great. Very nice. Pradhan, can you stop sharing, please?
Yes, sir.
Very nice. May I request the chairpersons to give their valuable opinion and some comments, and the audience also can ask the questions in the chat box. Dr. Vishal.
Call, sir. Dr. Call, sir.
Dr. THK Call, sir. Yeah.
All the speakers were excellent. All the three, very, very valid and very good point. Everyone has done an excellent job. I have a few points in my mind. When we are talking of the cement-induced hypotension and the anaphylaxis and the problems associated with it, is there any idea, is there any thought of the cement being replaced by some other material? I want to ask the speaker, is there anybody thinking about it?
Yes, Dr. Dev Sanjanak, sir.
Yes, Dr. Dev, he has otherwise presented very superbly, highly impressed by his talk. But is there something to, some idea that can it be replaced?
Thank you for the kind words. And obviously, the biotechnology world is continuously looking at items which doesn't simulate a bone cement implantation syndrome. The point over here is the comparison today only exists between uncemented and cemented processes, and there is a long series of cases which actually shows that the long-term cost as well as the implication of doing an uncemented prosthesis doesn't actually stand in today's days and time. We are also seeing that BCIS has happened without a cement also, so it could be something related to the reaming of the long bones also. But obviously biotechnology is continuously working towards items or materials which doesn't simulate a similar reaction. So the search is on, but no success as of yet.
The search should continue. So the search should continue because
Yeah.
the main problem, if it is removed, we may breathe comfortably. Thank you very much.
Thank you so much, sir.
Thank you, Dr. Nishant. Thank you.
Right, sir.
Dr. Nishant, you need a lot of praises. You have conducted the session superbly. I have watched right from the first word till this time. Completely, I have heard each and every word. You have really conducted it very nicely. You must have done a very tough job, hard
Sir,
job.
thank you
God
so much. Yes, sir. Thank you so much for the kind words. And it is actually the quality of the speakers that we have today
bless.
that
Definitely.
has actually been the best.
Selection of the
Sir,
I think we have lost connection with
right.
Dr. Dr. Ranganath wants to say something. Dr. Ranganath, sir raised.
Hello.
I think we have had wonderful presentations from Dr. Sanjay, Dr. Ashok, and Dr. Pradhan, and it was so interesting and so apt. And the intraoperative emergencies, these are all the dreaded emergencies which we all face in day in and day out. Yes, madam, you want to say something, please?
Dr. Ranganath, yes.
Sir,
Yes,
actually,
please.
to replace bone cement, there are research ongoing on bone glue. Actually,
Yes.
that is not yet in a clinical practice, and there is no heat generation and not mechanical bonding. It is a biological bonding. Mainly calcium phosphate based adhesives will be developing. So, one more thing that will replace the bone cement in future.
Very right, sir.
There are some questions, Dr. Vishal, in the chat box. If you allow, then we can take that.
Please take it, please.
So, Dr. Konda Reddy wants to believe, Pradhan, whether ipratropium is useful for chronic asthmatics or acute asthmatic patients.
Ipratropium is mainly used for acute attacks. So whenever there is bronchospasm in moderate to severe bronchospasm, which is not being relieved by use of isolated use of salbutamol, then only we use the ipratropiums.
Okay. Dr. Vineet is wondering whether after URI we should wait for 6 weeks or 4 weeks, and what practically do you do?
Sir, as per the book mentioned duration, it is 4 weeks. Ideally, wait for 4 weeks. Only in case of urgent surgeries or emergency surgeries, definitely we won't get any time. In case of urgent surgeries, then we try to push it beyond 2 weeks, 2 to 4 weeks. If at all you have, it's an completely elective surgery and you have time, definitely push it beyond 4 weeks.
I don't think there's any further question, Dr. Nishant.
Right.
And it was
Okay,
such a
yes.
wonderful presentation from all the three speakers. You may please take up the vote of thanks from Dr. Nishant Sahai, please.
Right. Thank you so much. And to begin with, I would like to thank our patrons, Dr. Kaul sir and Dr. Naveen Malhotra sir, the President RSA, for the encouragement that they have always provided to us, to the juniors. I would like to thank the speakers, Dr. Dev Sanjay Nag, Dr. Jadon sir, and Dr. Pradhan. I'm sure everybody has appreciated the way they have presented really nice presentations. And the executive of the RSA, Dr. Vishal Singla sir, Dr. Sunil Sethi sir, Dr. Swati Chabra, madam, and we saw the past presidents also. Dr. Indrani ma'am was here, and all the senior Dr. Reema Meena madam was here. Dr. Tanveer, I'm sure I'll be missing a lot of names, and not just the RSA national dignitaries. We had a lot of seniors from our state also. So thank you everybody for attending this webinar, and hopefully we want to do. And thank you for attending the webinars.
Thank you very much, Dr. Nishant. It was wonderful to have you here, and it was a wonderful session. And once again, I would. Yes, please go ahead. Once again, I would like to welcome all of you to 34th National and 5th International Conference in Indore, RSCP Con 2026. Please mark your dates 10th to 12th April. Thank you very much. Good night and long live RSA.
Long live RSA.
Long live RSA. Good night, everyone.
Long live RSA. Long live RSA.
Thank you very much, sir. Good night, sir.
Good night.
Good
Thank you so
night.
much.
Good night. Good night.
Good night, sir.